Hello and welcome to the second presentation of the Spring 2019 season of the Medical History Interest Group. I'm Melissa Nalcia and the History Collections Librarian for LaPus Library. The Medical History Interest Group presentations are sponsored by the LaPus Library History Collections in the Department of Bioethics and Interdisciplinary Studies. If you haven't already done so, please sign the attendance sheet before you leave. And we're doing fine on chairs. If you are attending as part of the ECU Wellness Passport Program, please see Lane Carpenter after the program for your stamp. Refreshments are available there. Excuse me. On the other side of that window, please help yourself. Upcoming presentations are Monday, March 25th, with Pierre Fauchard, the father of modern dentistry. The presenter will be Valdemar de Rijk, retired from the School of Dental Medicine and now in the Department of Physics. On Tuesday, April 9th, we will have the Transformations of Autism with Jeffrey P. Baker, MD, Ph.D., Professor of Pediatrics and History, the Director of the Trent Center for Bioethics, Humanities, and History of Medicine at Duke University School of Medicine. The History Collections Room, down there, has a display on the Country Doctoring Museum 50th Anniversary exhibit. There is a second floor exhibit entitled The Armstrongs of Rocky Mount, 3 Generations, 3 Doctors, and More. The other exhibits are all on the 4th floor around us. There's a pop-up exhibit about public health nursing in North Carolina, and near it is Life and Limb, the Toll of the American Civil War, and in the front we have scientists and their microscopes. Today's presentation is a history of public health nursing in North Carolina. Our presenter is LaShanda Brown, Ph.D., GNP, Assistant Professor, School of Nursing, North Carolina A&T State University. Dr. Brown is a nursing faculty member at NC A&T State University. She completed her undergraduate degree at UNC Chapel Hill, her MSN as a gerontological nurse practitioner at Duke University, and a Ph.D. in nursing history at UVA. She practices as a nurse practitioner part-time, doing geriatric psychiatry in skilled and assisted living facilities. Here is LaShanda Brown with a history of public health nursing in North Carolina.
So let me start with kind of really why I'm here. You see, my clinical practice is in geriatrics, so of course I love geriatrics. But at UVA, one of our required courses was a history of nursing course. I went into this course with no intention whatsoever of getting into history. I was just like, yep, this is one of mine, got to check it off the list. Got about halfway through and just fell madly in love. I went to my advisor, I went to the chair of the History Center, because they're one of the few nursing programs that has an actual history, nursing history center, and said, can I please, please, please. So I begged and pleaded my way into that track and have been doing nursing history since then. So my dissertation is in public health nursing history, but it's a very narrow focus of what I'm going to cover today. The other disclaimer is the title of this is A Century of Public Health Nursing. But we're not going to stay for the whole century. I'm going to get through about 20, 30 years, and then we're going to wrap it up for the night so you can get home and rest. And you can cover the rest of the century later, okay? You got a deal? All right. So, now that's out of the way. Okay. So North Carolina has a long, proud history of public health nursing. For over 100 years, women and men armed with the latest scientific knowledge about hygiene, sanitation, nutrition, epidemiology, along with caring hearts, a desire to help others, and a sense of adventure to tackle dire problems with few resources in often remote and unwelcoming environments have become public health nurses. Black, white, and Native American North Carolina public health nurses have labored against fantastic odds to relieve suffering and make life better for people in their communities. Professional nursing began in North Carolina as it did across the United States in the late 1800s. Lessons learned by Florence Nightingale and her nurses in the Crimea, supplemented by the American experiences of lay nurses during the Civil War, paved the way for the establishment of the field of professional nursing. Some of these nurses, led by Lillian Wald, hang on 1 second. Stop that. There we go. Okay. Some of these nurses, led by Lillian Wald of the Henry Street Settlement in New York City, took the expertise they acquired at the hospital bedside out into the community. Instead of focusing on one person at a time, public health nurses claim communities as their patients. Around the turn of the 20th century, some nurses in North Carolina began working in neighborhoods, schools and industries, churches, and other aggregate venues to decrease suffering and increase the quality of life for those they touched. This presentation will highlight some of their stories. North Carolina was the first state in the country to pass a law regulating nursing practice in 1903. Public health nursing began in North Carolina as groups of public-minded citizens hired nurses to visit the sick poor in their communities, and you'll see this theme over and over throughout the presentation. According to Mary Louise Weish, who has a book out there on the table, The History of Nursing in North Carolina, Amelia Lawrison was the first public health nurse to practice in North Carolina. She was hired in 1904 by the Ministering Circle of the King's Daughters, an interfaith women's Christian organization, to provide home care to the sick poor of Wilmington. In 1911, the Wayside Workers of the Home Moravian Church hired registered nurse Percy Powers to work among the people of Salem, which is now part of Winston-Salem. In addition to providing home health care for people with acute and chronic conditions, Nurse Powers inspected local school children for health problems and provided education and follow-up with their parents as appropriate. She was the first school nurse in North Carolina. In that same year, 1911, the Greensboro chapter of the Tuberculosis Association, using funds acquired from the sale of Christmas seals, hired Greensboro's first public health nurse, Clara Jane Thornton Peck, to visit Greensboro residents with tuberculosis and other illnesses in their homes to help them follow recommended treatments. Peck began the school nursing program in Guilford County and was the first nursing director of the health department. Today in Greensboro, both a public elementary school and a family shelter bear her name. The Associated Charities of Raleigh also employed a visiting nurse in 1911. Around the same time, the Young Men's Benevolent Society of the Second Presbyterian Church of Charlotte paid the salary of a visiting nurse for their city. In 1912, the American Red Cross Town and Country Nursing Service was established to provide skilled nursing care and health instruction in remote rural regions across the United States. The Red Cross piloted this program in 4 communities across the U.S. Old Fort, North Carolina was selected as one of the first 4 towns to host a Red Cross nurse. The program proved to be very valuable and spread rapidly across the country. For several years, the American Red Cross was the largest employer of public health nurses in the United States. Between 1915 and 1935, 52 North Carolina chapters of the Red Cross shared expenses with the National Red Cross to employ town and country nurses in their communities. The American Red Cross was one of the first healthcare organizations to integrate its workforce. Nurse Frances Davis of Shelby, North Carolina, was the first African-American nurse employed by the Red Cross in 1919. These early public health nurses were joined in the decade of the 19-teens by public health nurses employed by local government agencies. In 1910, the city of Asheville hired Jane Brown, an RN and graduate of the Watts School of Nursing in Durham, to provide general follow-up bedside nursing for patients discharged from recent stays in area hospitals. In 1916, she became the first school nurse in Asheville, paid by money raised by the local PTA. The Asheville Association for Public Health Nursing formed in 1919. Representatives from the Associated Charities, Red Cross, the PTA, of course, Ministers Association, Metropolitan Life Insurance Company, the Medical Society, and Mission of Good Samaritans of Buncombe County, and the Commission of Public Safety met to fund, support, and oversee public health nursing in Buncombe County. In 1912, the Durham County City Health Department hired Mrs. Clyde Dixon as a visiting nurse. And in 1915, Mrs. Emily Pickard was hired by the Durham City School Board to be the first school nurse in Durham. By 1917, 2 nurses were providing general bedside nursing for the sick poor in Charlotte. One was paid by the Metropolitan Life Insurance Company, it's another theme there, and the other by the Young Men's Benevolent Society of the Second Presbyterian Church. In 1918, a worldwide pandemic of Spanish flu killed millions. Many North Carolina citizens suffered and died from the flu. On October 24, 1918, the entire city of Charlotte was quarantined to prevent spread of the flu in or out of the city. Many nurses became instant public health nurses to provide care for those isolated from their families until they recovered. Possibly as a result of seeing how beneficial public health nurses were during the flu epidemic of 1918, just 4 years later in 1921, there were 17 public health nurses in Charlotte, and they were paid by various agencies, including the American Red Cross, 2 textile mills, and the city health department. By 1927, numerous civic clubs, including the Charlotte Women's Club, the Goodfellows Club, the Civitan Club, and the Kiwanis, were all supporting public health nurses and clinics for infants, children, and pregnant women. Guilford County hired Mary Horry, an RN, to do infant relief work in 1918 and 1919. In 1919, they hired Mrs. Blanche Lamb, who became the first school nurse hired by a county health department in North Carolina. Columbia Munns wrote a report to the county health officer of New Hanover County in 1928. She noted that on May 1st, 1915, the Board of Health hired the first nurse to perform school nursing and infant welfare work in the county. By 1918, the city of Wilmington employed 4 public health nurses and 1 nursing supervisor. In 1921, the Jewish Women's Federated Charities sponsored a nurse. And in 1923, enough money was raised by African American civic organizations to hire a school nurse for the segregated African American school, which apparently had not been receiving adequate, if any, coverage services from the white school nurses employed by the county. The next year, 1924, the county used public funds to help pay the salary of 2 African American public health nurses. By 1928, public health nurses funded by a variety of sources provided bedside care for the acutely ill, prenatal services, infant welfare, tuberculosis care, and school nursing. These nurses combined logged in over 21,000 nursing visits in 1928. A notable exception to the pattern of nurses being hired by benevolent associations and local governments to provide some measure of public health, home health, and school nursing was the work of Lydia Holman of Mitchell County. Lydia Holman came to the small town of Ledger in the mountains of North Carolina in 1900 to provide private duty care for a wealthy woman who was very ill with typhus at her vacation home in Mitchell County. Holman observed many local people suffering from blindness, deafness, orthopedic deformities, premature deaths, and illnesses, and illnesses that could be prevented, and she realized she had to do something about these conditions. Traveling on horseback over tortuous mountain roads, upstream beds, and over the high mountains, she delivered hundreds of babies, performed minor surgery and dentistry, immunized folks against typhoid, and fought epidemics of tuberculosis, pellagra, smallpox, and measles. This wiry little woman spent 58 years caring for rural Appalachian families in and around Mitchell, Yancey, and Avery counties. The range of Holman's accomplishments is staggering. She was a nurse, a midwife, health educator, a dentist, a social worker, and sometimes a physician for hundreds of people in a 60-mile radius. Ledger, at that time of Holman's arrival, was an isolated Appalachian village about 30 miles from the nearest railroad, with no paved roads, no electricity, no running water, no newspaper, no hospital, and no trained nurses. As her patients' health improved, Holman was increasingly called on by local residents to attend to their illnesses. Now, just a little side note, I was a public health nurse, and I used to whine about having to drive an extra 30 miles to go see a patient. And then when I started hearing these stories, I was like, well, at least I'm not on a horse. Ms. Holman made a study of the living conditions of the people and found them lacking in many respects. She became attached to the mountain folk and felt that she could be of use to them in combating disease and teaching hygiene and dietetics. For many years, she not only did her housework and cooking, but cared for her horse as well. At any hour of the day or night, she answered the calls of the people, riding alone for miles to attend a person in need. Her arduous duties have been attended by danger and discomforts. In a 1915 report to her supporters, Holman described some of her activities as teaching classes in hygiene and nutrition, working to control epidemics of chickenpox, scarlet fever, measles, and camp itch, holding an immunization campaign against typhoid, and distributing donated toothbrushes and toothpaste while teaching the importance of dental hygiene in the community. In addition to her nursing work, Holman established a small lending library, kept a demonstration garden so people could learn to grow a wide variety of fruits and vegetables to supplement their diets, and distributed hundreds of donated toys at Christmas. She was like a real-life hero. I mean, come on now. As the years went by, progress came to western North Carolina, including Mitchell County. A few physicians moved into the area and were upset by the breadth of Holman's work and had her arrested for practicing medicine without a license. Holman later wrote about this experience this way. These are her words. "It was nicely done. The arresting officer read his warrant and said, 'Now, Miss Holman, don't let it worry you. It'll cost you every cent of $50, and I would not do it. There ain't no reason why you should pay anything.'" This was the officer talking. "I took the man's advice and spent the whole day waiting for the people in the courtroom to decide what was to become of me. The solicitor read a very nice little piece of scripture and dismissed the case." After court, 20 mountain men or more took credit for having the case thrown out. Then they came to assure me, all the neighbors and people I had never heard of, that I should go on with the work. They would be quite willing to hire teams and come to my defense again if need be. I think they liked her. Yeah. She did continue with her work. By the 1920s, state and federal monies were starting to become available for public health work, and Holman was put in charge of administering these funds in Mitchell County. In addition to intelligence and care, Holman also demonstrated ingenuity. This is where the car comes in. By 1930, there were sufficient paved roads in the county to make traveling by car faster. Of course, she still had a horse, and easier than horseback. Holman had no extra funds with which to purchase a car, so she wrote President Herbert Hoover saying that if she had a nice car, she'd be able to drive voters to the polls to vote for him in the upcoming presidential election. Yes. And guess what? She got her car. Soon, a brand new 1931 Model A Ford was delivered to Holman from the White House. Yep, she's officially a hero. In 1936, at age 68, Holman was elected to the Mitchell County Board of Health, becoming the first female elected official in the county. Holman spent her retirement years in her beloved Mitchell County, dying in 1962 in the VA hospital in nearby Asheville. She's buried in a plain grave in the Spruce Pine Cemetery, close to where she spent her life in unselfish service to her fellow citizens. Now, this is another side note. The public health nurses that I studied in my dissertation had very similar stories. They weren't just giving immunizations, they weren't just doing nursing care. They had this all-encompassing role, and they were just a really intricate part of the community that people just really, really appreciated. So I think as you dig deeper, if you dig deeper, I encourage you to do so, you'll see these nurse heroes scattered throughout the county in places where there were no other providers. So when I saw that about the case and her practice in medical care, it's just such an insult, because a 60-mile radius, there was no one to provide any type of care. So it just almost seems like a slap in the face to then come back and be accused of something when you were doing what needed to be done. Back to 1919, off of my soapbox. Following the lead of city and county governments, the state government of North Carolina began its involvement in public health nursing. In that year, 2 programs funding public health nurses were initiated. The first focused on school health nursing. 6 school nurses were hired by the North Carolina Department of Public Health to assess school children across the state for growth, dental status, infections, particularly of the tonsils and adenoids, and to look for other less common problems. The nurses inspected each child from 1st through 6th grade at 3-year intervals. The first 6 nurses who worked together for over 18 years were Cleone Hobbs of Clinton, Bertie Dunn of Raleigh, Cora Beam of Fallstone, Kate Livingston of Wagram, I may be saying that wrong, Flora Ray of Sanford, and Mrs. H.P. Guffey of Statesville. Their first biennial report, released in 1921, shows the nurses inspected 92,566 children and conducted clinics for immunizations, tonsil and adenoid removal, so they were doing minor surgeries in the schools, and dental treatments. Yeah, minor surgery, just another part of the job. They also provided hundreds of health lectures to parent groups and to teachers about a wide variety of topics. Many years later, Weiss wrote about the nurses in this way. They have traveled on foot, horseback, on rafts, by boat, tram cars, ox carts, any way to reach the forgotten child. Also in 1919, the state partnered with the American Red Cross to establish the Bureau of Public Health Nursing and Infant Hygiene. Nurse Rose Ehrenfield was appointed its first director. Its mission was to improve maternal child outcomes in the state. In 1921, a year after women got the right to vote, the federal government became involved in funding public health nursing programs. The U.S. Congress passed the Shepard-Towner Act over the objections of the American Medical Association. This legislation authorized federal aid to states for maternal and child health and for welfare programs. States had to provide matching funds. Using 27,000 of Shepard-Towner Act monies and state funds, on April 1st, 1922, North Carolina reorganized the Bureau of Public Health and Infant Hygiene into the Bureau of Maternity and Infancy. Under Nurse Ehrenfield's leadership, a program of midwife education and supervision began. In the 1920s, over 30% of births in North Carolina were attended by the approximately 5,000 lay midwives in active practice at that time. Childbirth was the leading cause of death for women of childbearing age. And that's thrown in there, but there's not a direct association. It wasn't because we had 5,000 lay midwives. We had 5,000 lay midwives because there wasn't a very specific OBGYN specialty at that point, and there definitely wasn't a number of those types of providers, physicians, to go out into these rural counties to do the delivery. So it was just a supply and demand thing. And as a whole, our healthcare profession was starting to focus on that and decrease the maternal and infant mortality rates. In 1920, the maternal death rate in North Carolina was 999 per 100,000 live births. And for comparison, today's maternal death rate is about 12 per 100,000 live births. In the early 1920s, the state legislature passed the Model County Midwife Regulations, which included requirements that lay midwives have a physical examination and instruction and demonstrations given by doctors and nurses in the procedures of a normal delivery. A lot of that was done by the public health nurses. A 1928 report in the Health Bulletin shows that state public health nurses delivered midwife classes in 30 counties in the state. In 1921, the U.S. Congress passed the Snyder Act, which is the principal legislation authorizing federal funds for health services to Native American tribes. In ratifying the Snyder Act, the federal government sought to provide appropriations for the benefit, care, and assistance, and for the relief of distress and the conservation of health for Indian tribes throughout the United States. The first North Carolina Eastern Band Cherokee registered nurse, Mrs. Lula Al Gloyne, was employed as a public health nurse using Snyder funds. Lula Al was the first of 10 children born to Daniel Lloyd Al, a Cherokee blacksmith, and Nettie Harris Al, a Catawba Indian and traditional basket maker and potter. Lloyd did not speak Catawba, and Nettie did not speak Cherokee, but both parents shared a basic knowledge of English, which became the primary language in the household. Mrs. Mary Wachacha, Lula Al's granddaughter, surmises that the Al children's mastery of the English language explains why all 7 siblings who survived to adulthood went on to professional careers. Lula Al attended a mission school on the Qualla Boundary and then went to Hampton Institute in Hampton, Virginia to complete her education. After graduating from Hampton in 1914, she spent a year in the classroom teaching Catawba children in Rock Hill, South Carolina. During that year, Al decided to follow her calling to become a nurse. Mentors from her Hampton days arranged for her to enter the Chestnut Hill Hospital School of Nursing in Philadelphia. She graduated in 1916, earning the Gold Medal of Obstetric Nursing, and became the first Eastern Band Cherokee nursing graduate in the country. In 1917, the United States joined the Allies in fighting World War I. The Red Cross and the Army Nurse Corps encouraged all registered nurses to serve their country during wartime. Al had planned on going to Europe to be a field nurse for the U.S. Army, but failed the seaworthiness exam because she had extreme seasickness. Instead, she was assigned to Camp Lewis in Washington State as a second lieutenant in the Army Nurse Corps. I was the only Eastern Band Cherokee Indian to serve as an officer in World War I. While at Fort Lewis, Al married a white enlisted man, Jack Gloyne, and after the war, they made their home in Cherokee. At that time, around 1920, Cherokee did not have a hospital or a full-time doctor. Gloyne was the first professional healthcare provider available to help the people on the Qualla Boundary. She recalls her early years as a nurse in Cherokee this way. There was no hospital in Cherokee then, just a clinic at the Quaker grade school and a doctor who worked there part-time. When I came home, they asked me to help out, and at first I worked without pay. I did all the outside work, meaning outside the hospital or public health nursing. I got called to homes all around here. I didn't have a horse or a wagon back then, so see, she didn't even have a horse. Though some people had ox-driven carts and a few had wagons, so I had to make my calls on foot. I got caught in places too far from the doctor where I just had to do what had to be done. Men got cut up and I'd have to sew them up. Women would call on me to deliver their babies. Today it'd be illegal to do a lot of that, but back then there was no one else. Nurse Gloyne remained active in her community, providing nursing care and volunteering for numerous community organizations until her death in 1989. The stock market crash of 1929 led to the Great Depression of the 1930s. Leading to the Great Depression of the 1930s, changed the nature of public health nursing. The federal government, through programs such as the Federal Emergency Relief Act, the Civil Works Administration, the Works Progress Administration, and most importantly, the Social Security Act, funded programs that expanded the scope and depth of public health nursing throughout the country. These New Deal programs had significant impacts on the health of many North Carolinians. Tens of thousands were immunized against diseases, attended clinics, and received treatment for hookworm, syphilis, and other contagious diseases. Many were home visited by nurses for prenatal and home health care and were educated on many important health issues of the day. The Social Security Act, and more recently Medicare and Medicaid, fund specific programs instead of giving the money to the state and the local health departments to dispense as they see fit. So you start to see a little bit more of standardization of care in that aspect. What's happening in counties is starting to match a little bit more. For the last 75 years, most of our work in public health has been driven by which programs have been funded by the Social Security Act and later by Medicare and Medicaid. For instance, the Social Security Act made money available for maternal child health programs and for crippled children in 1935. Public health nurses could be hired using federal money for these two areas. In 1938, the Social Security Administration began funding sexually transmitted disease prevention and education programs. In 1944, added tuberculosis control to the list of federally funded health services. Local health departments responded by starting and or enhancing programs in the areas in which they could receive Social Security Act monies. The number of nurses employed by government agencies in North Carolina rose from 65 in 1933 to 297 in 1940, from the start to the end of the New Deal programs. The number of county governments participating in public health work increased from 47 in 1934 to 81 by 1940. In 1934, almost 2 million North Carolinians had access to at least some public health nursing. That number nearly doubled by 1940 to over 3 million North Carolinians. Due to these New Deal public health nursing programs, North Carolinians were experiencing better health, nutrition, and a generally better quality of life. Okay, so I'm going to wrap up at that part of the century and just thumb through a few more slides just so you get the visual of how the nurses were traveling and what a life sacrifice it was. A lot of times these women were traveling solo. I've heard stories of nurses along the eastern part of the state riding with bootleggers and catching the boat for out into the outer banks to get to patients, and you can imagine like that whole notion of a 9-to-5 job just wasn't even a thing for them. But they were really, really called to the profession, and it shifted my whole perspective of being a nurse once I started hearing some of these stories and just how creative we've gotten in the places that we work, and I see it happen especially in the homes and in the community. Having started off as a nurse and being trained in the hospital, and you get your standard way of how you're supposed to do things in aseptic technique, and then you get to a home out in the middle of nowhere where there may be lights. Even now, like not even back then, but there may be lights, and you'd hear the little rat pitter-pattering through the cabinets of the kitchen. It's a whole nother world out there. And so I really could relate to some of their stories, even 70 years later in my case. So I'm going to open the floor for questions or stories or whatever you see fit at this time.
If you haven't already done so, please sign in over here. And the refreshments are over there. If you have a question, please raise your hand and I'll take the microphone to you. This is because it's being recorded, and if you've ever listened to excuse me, if you've ever listened to answers when you don't know the questions, you know how confusing it can be. So yes.
I'm Dr. Susan Haynes-Little, a public health nurse here in North Carolina since the mid-90s. And my question is about what is the total time span of public health nursing history research that you did, either for your dissertation or otherwise?
For my dissertation, I did the 1920s and 30s, and mostly the 1930s. So just a little bit of the prep, and then I was really interested in that Depression era and the federal funding and how that shifted the care and the things that we did, and the availability of nurses. Because once that funding went away, there were a lot of nurses laid off. And so just those shifts, we see those shifts still happen with nurses in there, and there's a shortage of nurses, and then there's an overflow of nurses. And just interested to see how that played out during that time. Mm-hmm.
I was wondering, in your research, have you noticed how North Carolina compares to other states in the country in terms of the development of public health nursing and what they needed to do?
So let me start with a disclaimer that I was warned many, many times to stay focused. So I would wander off sometimes and look at Mississippi, especially their public health nurses, and they would say, nope, come back right here and just stay here. So the real answer is, I don't have a comparison of the trends because I was not allowed to look beyond my little. But the public health nursing, especially rural public health nursing, seems to be consistent across the South. Lots of similar stories.
Thanks for your presentation. Could you say something about the background to one of the first slides that you showed, which said that North Carolina was one of the first to introduce public health nursing? They were the first to pass the Nurse Practice Act, the first to have an official registered nurse. And I don't think it was that they were the first in that first, but to have public health nursing. But theirs looked a lot different. So I mentioned the Henry Street settlement in New York. They had, theirs would be more, I guess you could call it community health nursing. So they had people that were living congested in close quarters, lots of immigrants. And so they had to create a new field of nursing to care for those people because they had a lot of sickness and a lot of contagious things going on at the time. So what happened here was that our people that we were concerned about weren't living in close quarters. There wasn't a huge influx of people into the area. They were dispersed way out. So we had to take that model and shift it into something that would work for people that lived hundreds of miles from each other. So my question then is the we part of that. Was there some organization, what pushed North Carolina to be doing the things that it did in nursing? That's sort of a big picture question, but it just seems out of the blue. Do you see what I'm asking?
Yeah. So so there was a bigger trend of shifting from hospital care and acute care to shifting into the community. There weren't really enough hospitals to take care of everyone who got the flu or TB or whatever, so we had to figure out where we're going to take care of those people. That's where you see all the community organizations coming in. You've got the PTA saying, hey, we've got kids that are sick here with tonsillitis. What are we going to do about them? What if we hired a nurse? So community organizations started pooling their funds. There were a lot of women's organizations at that time too that were doing, their versions of community work, a lot of cleanliness campaigns and teaching people hygiene and sanitation, and they joined forces with the nurses too. So I think a lot of people had a similar idea and saw how nursing could really be instrumental in their movements, and they funded those nurses. Some of it probably came from relationships, personal relationships with a nurse, and they saw someone like Ms. Holman and said, that's what we need in our area, and so they specifically said, let's hire a nurse. But some of it just, it was probably just circumstantial maybe.
Sorry to prolong it. Just to follow up, your talk starts off with lots of stories around the state. It's sort of disparate. And what I found interesting was that it sounded like by the 19-teens or 20s that there was some unity, some central organization to it. But what you just described sounds like what you portrayed in your talk, that there were individual local places that started their own kind of public health interest to follow up on needs in that local area. And then somehow the state got involved, hired those 6 public health nurses, et cetera. So it's like a coming together.
Yes. It's a coming together. And money funds and fuels a lot of that. So where we were relying on individual separate funding, when you get the federal funding coming in, it makes things more uniform in that, like, you've got this American Red Cross organization, and they're hopping from county to county. They're setting up shop, they train the nurses, they go to the next place, and they train the nurses. So now everybody's not having to figure things out on their own. They're like, hey, over in Mitchell County, they're doing it this way, let's do this. And then you start to get this uniform movement and growth of the public health nursing movement. And at the same time, things like health departments are starting to get funded and appreciated, and they're growing too. So there's some simultaneous stuff happening. But yeah, it is beautiful how it all kind of comes together. Mm-hmm.
You're on the way to him.
On the way to him. Hello again. I really appreciate the conversation about what appeared to be fragmented approach to getting community and public health started, because that's sort of where we are today, as we're branching out and trying to explore what the needs are for the uninsured, and we're beginning to try to approach that as individual entities, and some of the same ones. The churches you mentioned in there, brotherhoods, we see them doing that. We see other community interest groups deciding we want to have a free clinic or service to be able to provide access, and so they're doing something very similar. So it seems like in community and public health, that framework is always a grassroots start that funding kind of follows, is what it appears to me.
It is. And what I like about looking back at the history of it is, not only seeing that we go full circle usually, like, things come back around, but looking back to see, how was it? What were the themes? What were the trends? And how can we start there instead of reinventing the wheel? How can we partner with women's organizations and other communities, the churches, and how can we partner and keep the preventive care in the community and build faster for what needs to happen right now? Because we are moving back out of the hospitals and back into the communities again, back into the schools. We went through a period where they stopped hiring a nurse for every school, and schools are sharing nurses, but as care is shifting out of acute care and more towards a preventive focus, they're going to have to start having more nurses on site. I've gone to public health, I've gone to middle schools that have a clinic in the school, and it has a nurse, has a therapist, there's a PT and an OT there. Like, they're moving real deal clinics into the schools. I love to see stuff like that happen, because that needs to happen. Another trend that happened around that time, which may or may not happen now, is that nurses were partnering with the teachers, and so they would go out and they would train the teachers to do some health and hygiene education. Now, they could fit it in their curriculum then. We haven't figured out a way to fit it in as much now, or maybe we're calling it something different, but there was this partnership because they understood the need to educate. They understood the impact that educating the children had on the whole family. You teach a child how to properly brush and floss, then they're going to model that behavior to siblings, to parents, to this, that, and the other. So I think that's a powerful avenue that, we can definitely take advantage of even more.
I wanted to follow up on Dr. Savitz's question about the early history, and I wondered, a parallel history of this School of Public Health at Chapel Hill, which has long been one of the top in the world and has a very close relationship with the legislature. I wondered the interplay between them and the health departments and public health nursing, especially in the early days.
I know that one of the first public health nursing programs came out of that School of Public Health at UNC. So they at least took the lead on starting to, because public health nurses did an additional training to be called community health nurses, and that was one of the places that they could go. So yeah, they were definitely on the forefront of that formalized community health education, and I'm sure research and all that good stuff too. And because they had that tie, then they could, they had a voice in funding and legislature and how those types of laws were enacted. But yeah, they were definitely on the forefront.
This is not so much a question as a comment that would respond to his question earlier. in 2010 through 2012, there was a Rural Nursing Council of Eastern North Carolina that encompassed Lenoir County, Jones County, Greene County, and of course ECU helped support, the School of Nursing at ECU helped support that. But we had people from the health departments and from the schools and from the hospitals, well, the only hospital was Lenoir Memorial at that time, in those counties. But we came together and met over that 2-year period trying to determine how we could best support the health and well-being of the citizens in those poorer communities, some of the poorer communities. And we looked at the schools and the involvement we had in the schools. And so we met on a weekly basis for a very prolonged period of time, active, trying to initiate programs that would help with nursing in the schools and in the younger generations, bringing them forward. So it came out of that kind of a collaborative effort, seeing the needs that we had.
Yes. And what that makes me think about, one thing I really noticed when I was doing my research is that the far eastern part of the state and the far western part of the state had these same types of lots of rural areas, lots of need, very few providers. So they were probably working like crazy just to provide care for people, which doesn't leave a lot of room for weekly meetings. So that's where the gap is. You don't have time to collaborate and collect and have a collective voice when you are working so hard to provide the care, but they still have the biggest, they really should have the biggest input because they're being the most creative and the most productive, and we need to hear what they're doing. Because in the central part of the state, where we have lots of hospitals and highways and folks coming in and out and migrating here, we've also got lots of providers and lots of hospitals and lots of funding so we're good, so to speak. You know what I mean? Not good, but compared to what they're doing, we need to hear their voice. Even now, back then, but especially now, and it was just 2 years, you said? I'm not surprised, because it's different work. It's not sexy like being a cardiac nurse or an ICU nurse, like you're a public health nurse, and people think that, whatever, they're not really coming asking for questions or creative solutions to anything, but we're doing good work, so.
So I'm curious, I went to UNCG and hung around Greensboro for a little while after college. I'm a public health nurse, and one question was, did you practice public health nursing here in this state?
In Forsyth County.
In Forsyth.
Mostly Forsyth County. When I worked for Baptist doing home health chemo, Wake Forest Baptist Hospital has a pretty far, like 100-mile reach, so I was in quite a few counties there. But I have worked in North Carolina as a public health nurse and as a nurse practitioner working out in the community.
So I'm just curious, at your university where you teach now, what kind of education do they teach the nursing students in regard to public health nursing, and do they emphasize the home visiting and the community as the patient, and what kind of, because in my job, we have a hard time finding nurses who want to come into public health. So I just wondered if you could speak to what kind of orientation or experience they're gaining about public health nursing at your university.
I can speak more to Appalachian State because that's where I was for the last 2.5 years. I just got to Greensboro in January. So in the western part of the state, we had a lot of challenges with finding sites that were able and willing to house students. So some of their community health experience was in outpatient clinics and not necessarily doing home visits. They got to do some, especially with hospice, they would get to go out into the homes with hospice. That is a challenge, finding them enough variety of sites to give them a real exposure to what community health nursing is. And at the same time, we pound into their heads, you've got to get your year of med surg, and most of them are going into acute or ICU now, and they lose that whole community health experience or love or passion by the time they graduate. And so I think it's unfortunate because I want them, or a lot more of them, maybe not all, but I want more of them to go into community health. But there's just, it was just a challenge with finding the variety of sites that they needed. So some would go to the same sites over and over, but yeah.
Well, can you share any example of a student that really got turned on by public health and community health nursing when you were teaching? I'm just curious because we're doing a recruitment and retention study for the public health nurses across the state, and we're struggling with this. And also we have one ear to education and trying to figure out exactly how to bring more nurses into public health nursing who appreciate and want it for the population health focus that it was designed to be, and not the clinical necessary that it's come to be.
Yeah.
I'm sorry.
Now tell me the beginning part of your question
So
again.
do you have
What's the
do you have any
answer?
do you have any story from a student that told you something about their public health nursing experience that you can remember that they thought was just really cool? I'm reaching for straws, I know, but I'm just trying, I mean, because you're a young person, you've become enlightened, and you're so energetic about public health nursing. I want to find more people like you. So,
the magic is in getting them back into community health rotations during that internship phase or residency phase. If we could get a longer exposure towards the end of their rotation, I think you get more people that would cycle back and actually land in community health. What happens is they'll take community health one of their first 2 rotations, and then they've got maternity OB, and then they've got intensive care, and then they've got all these things that follow that, and then they're focused on NCLEX, and then they do their externship or residency, and it's almost long forgotten by then. So I think it needs to be re-exposed towards the end, or let their rotation for community health be closer to the end when they can work more independently. And because also when they're in the community doing those rotations, a lot of times they're standing back observing. And so their experience of community health nursing is standing behind another nurse, looking over the shoulder and going, oh, okay, it looks interesting. And they don't get a lot of hands-on. I feel like if they were seniors and towards the end of their experience and they were more hands-on, and they were doing more even injections or immunizations or education campaigns. Like we tried to get them to do education campaigns on campus because that's their community. So why not do the education there for their fellow students? To get more of a hands-on experience of developing a program and delivering it and recruiting and all the fun stuff that goes into all that. So that was helpful and it got them engaged, but it is a challenge.
Anybody else?
Thank you. And the interest group, you've done a fantastic job. I'm a reporter for the East Carolinian, and I just wanted to ask you a simple question. You're doing all this work part-time and being a practitioner. My mother was a registered nurse. That's why I gained the interest to do this story on your lecture today. And are you continuing any other research as of right now? I know the time is really of the essence, but of course.
Yes, I am. So my passion right now, because I like preventive care and looking at things from a holistic perspective, is the impact of teaching mindfulness to people to help manage long-term chronic stress, which impacts so many chronic diseases. It's more a part of my public health and geriatric mind than it is my historical research type of mind, but mindfulness practices for people to provide, to empower them to take care of themselves and to take them out of that curative, you've got the answer for me kind of mindset. Teach them that if they slow down, if they feed their brain, if they do the mind-body connection piece, that it will change things like hypertension and diabetes and anxiety and depression. It will help them learn to manage it on their own.
Thank you. I appreciate that.
Well, I have a question. When I was seeing towards the end, maybe about 1937, in the Depression years, and I'm old enough that my parents were born in the 20s, so and my dad was involved in some of the I think he did CCC work. But looking at those kids who were really spindly, I don't know any better way to describe it, and they're talking about they're going to these camps and they are basically, in effect, putting meat on their bones. Would, and this is speculation, do you think that that had a lot to do with the ability of the U.S. to fight in World War II?
What I think is that it had to do with poverty in North Carolina, the rates of under and unemployment, the amount of people who were farming and may not have been productive enough to really provide for their families. And I've read enough nursing stories where their nursing care was to go to the local market and borrow food or barter with the store owners to bring food back to the homes because of things like pellagra, where if we could just get them nourished, then they had a fighting chance of recovering. So poverty seemed to be a common thread in the 3 zones of North Carolina that I looked at, bigger than any of the political, economical, well, that's economical, but any of the outside influences. I think that was the biggest influencer.
Any other questions? In that case, thank you very much.
Thank you.